So, hello, Dr. Kapardhi.
Okay. Yeah, doctor. Good.
Can you
Good
hear
morning.
us?
Good morning.
Good morning.
Good morning, chairpersons. Yeah, we can able to hear.
So, we are here to see you
welcome to IJCTO
introduce the
2000
case and the operators and the staff.
Okay. Yeah. So, welcome to all on behalf of IJCTO 2019 to live case of Hyderabad, and our staff actually, Chief Technician Mr. Lakshmi Narayana, as well as Vijay Madam and Bharati Madam, and our colleagues Dr. Vishwanath and Dr. Shivra Prakash is there here, and Dr. Okamura is operating. And regarding clinical details, I will hand over to my colleague Dr. Kapil, who will just describe about the clinical presentation. Please, clinical presentation.
Yeah. Hello. Good afternoon, everyone. This is Dr. Kapil from Apollo Hyderabad. Today we have a 60-year-old male diabetic and hypertensive presented with class 2 angina at a different hospital. He has evidence of anti-wall MI on 2D echo, and he underwent coronary angiogram which showed LAD disease and PDA, and PTCA to LAD was attempted at a different hospital. Then CAG and CD was sent to us, and we have reviewed the CAG CD, and we have advised PTCA DES to PDA, and we have done it on 29th of last month, and we gave some time, and now we are taking the patient for a PTCA to LAD, and his EGFR is 90 ml per minute, and the angio is as follows.
For anchoring?
When was LAD attempted previously?
PTCA to LAD was attempted on it, yeah.
When was it previously?
Next. And it was attempted, sir.
When was it? When?
Now this is a dual injection.
Volume mention.
It was 8 weeks back, sir.
No volume. Yeah.
And this is a dual injection showing LAD proximal, osteoproximal LAD CTO, and it is distal LAD is filling retrogradely through septal collaterals, and we have a conal artery giving us collateral to the LAD. Next. This is a.
Was the viability established in the LED territory by any means?
No, sir.
Okay.
Was it short? Was it short left main or absent left main? Is it absent left main or is it short left main?
It's a short left main.
It is absent left main actually.
Because that
Almost
makes
near
you more
simultaneous
safer
absent.
actually.
Next.
So there was no viability test, despite having evidence for a previous MI in the anterior wall. That is a matter of debate whether you should.
Second thing, he had only class 2 angina, which is more subjective actually.
No.
So, okay.
He doesn't have any
You decided to go for PCI here.
Function.
Okay.
Yeah.
So this basically is a short occlusion with no stump. So it has JCTO score certainly 1. The previous attempt is always an issue, how serious was the previous attempt, but definitely the stump morphology is a little bit unfavorable.
Do you have his previous angio to see how was the change made after previous attempt? Because that can decide the plan actually.
Kapardhi, are you able to hear us?
No. Yeah, I can able to hear. Actually here there is no significant change compared to the previous angio, because basically it is a stumpless CTO, and in other center it was tried with some equipment, but it is not a dedicated attempt basically. And it comes under stumpless CTO. That's why the strategy of Dr. Okamura is I was guided puncture of the proximal cap because it is unable to see,
IVAS.
the stump is
IVAS
unable
more
to see angio, but we can able to see an IVAS. Now the strategy and what are the steps Dr. Okamura will explain, but before that one, we follow all the radiation safety precautions also in this patient, because we took 8 French sheath as well as 8 French guide for any feasibility of real-time IVAS puncture.
No.
And second important, rad pad also we used to minimize the scatter radiation. And contralateral, we took a 6 French sheath and catheter for a distal vessel guidance and all these things. Dr. Okamura, can you explain what are the things you did now and then next?
Yes.
Segment seems to be very small. Then are you planning for antegrade?
Yes.
IVAS guided?
Yes. Yes, exact.
Yes. Please show the today's angle. I check the. Okay,
Yes,
please.
this is the angio.
Please pray. Okay.
Can we
So
have
angio.
the volume of Dr. Okamura higher? We cannot really hear.
Higher.
Yes.
Please.
Okay.
Yes.
So will you show the angle?
Angio.
Angio.
Today's angio, please. So today's,
yes,
this is the
yes.
angio.
So the entry point is not clear. So that's why I advance the wire interceptor and I check the eagle eye. So eagle eye shows that the entry point is a little bit 5 millimeter proximal of this angiogram, the tip of the guide wire. So next.
Which wire is it?
I advance the guide wire, and then this is a Sion. This is Sion. And then go next, and go next. I want to check RO coda from the retrograde channel, but the retrograde channel is very weak. There's a possibility of the distal part, but it's very small one. And the conus branch to the good collateral from the exit. And next, please. And I want to do the selective tip injection for the distal part. I advance the carnabel into the conus branch. Go.
Next step,
Go,
please.
go.
Next
Go,
step.
go, go,
Next.
go, go,
Next.
go.
Next.
Go,
Caravel injection. Please show the caravel injection, please.
Yeah, here.
Here, this is the one.
Yeah. We can see the distal part just now. So the problem is the antegrade entry point. The next one, please. Next. Yes, next. Yes. This is the entry point of the.
IVAS.
Yeah. No. Yeah. So next, please. Yeah. Here. This is the entry point. And
Can you
next,
show
please.
us the IVAS for that
Yes.
position?
Yes.
Yes. Yeah.
Yes.
Can you show the IVAS? The proximal cap. The first run, can you show?
Yeah, we see the IVAS.
So real-time IVAS guidance is very difficult, impossible by using eagle eye. If we use the pullback system, real-time is possible. So that's why I just put the IVAS just beyond the target, and I advance the guide wire into the LED side. Maybe the sector is a lower side, so that's the right side there is a target. So eagle eye is difficult to do the real time.
Yeah.
So that's why I just only advance the guide wire around this part, and I make sure that the wire is inside the room.
But on this run, we don't really
Okay,
see
because
the entrance.
eagle eye is bulky. No, you can see the first run, you can show. The cap, they can easily, you can identify. Please show the run, first run.
We are unable to
This
see
is
the
a real
actual-
time, but first run.
Yes. Do you see the entrance? The 6 o'clock, 5 to 6 o'clock. This is a sector. And a little bit pullback.
Okay, there is a calcium ring.
Yes,
exact.
So real
Then-
time is just
Okay.
now. Please.
Recorded one, can you show?
Live, please.
Yeah.
Live is better. So I put the IVAS. This is live.
Yes, live.
This is live.
We
the
apologize, but
target is
we need to leave you quickly because the other lab is in starting position for some time. So they will present the case. You proceed with the puncture and record everything, and we will come back immediately as soon as possible.
Okay.
Yes, yes. I'm just, I will explain. So maybe just now I passed
Can you show angio, please?
separation.
Okay.
So, but I will explain the passage of the entrance point. Okay, 16 atmosphere.
Okay, 16.
Okay. I down, please. Okay, so please back to the, maybe the 6 or 7 frames.
Back, please.
6 or 7.
So
Puncture
explain
of the
which
plasma.
wire did you use?
Angiographic and IVUS, both.
Okay.
Yes, yes. Conquest 12 gram.
Right in the
So,
beginning.
Yeah.
Firstly, UB3, admittable 3. So I check the entry point by using the IBUS. This is the entrance. But the IBUS disturbs the wire movement.
Corsair.
So
Corsair.
that's why, this is after the passage. So one back, please.
One frame before, yeah.
One frame, yes.
Yeah.
Yeah, this one. So I marked this point by the IBUS catheter using the angle. Then I advanced the guide wire. Firstly, under the IBUS, I advanced the UB3, but the IBUS disturbed. Also, conquest is disturbed. So that's why I pull back the IBUS. Then I advanced the wire, maybe the marker point. Firstly, UB, but I moved to the conquest. Because right side, upper right side, there is the two lumen, was the main branch. So I advanced the conquest wire into here, and the next one, please. Then I confirmed. The next one, please. I confirmed the wire into the two lumen. So can you see the IBUS?
IVUS, you show the images. Images.
The wire is the wire shaft is in the center point. So I'm very interested in the IBUS guided wiring, but IGRA is also very important to see the wire shaft.
Okay. Okay.
But if we wanted to see the real-time guide wiring,
Okay.
thinking about the 3D image, pullback system is better. Because if we use the pullback system, you can see the guide wire shift and also the guide wire tip. If you see the guide wire tip, you can understand the rotation direction. So that's why IGRA is good IBUS because of the short tip. But also this kind of the situation, the sector is wire going. So that's why you advance the optical IBUS, then pullback system. You have to see the wire shaft and also the guide wire tip and to penetrate real timely.
Right.
But this is also work. So just now I advanced the wire in the mid part of the distal
LED.
part of the
Yeah.
LED. Show me the angle, and I check the angle from the proximal part of the tip injection. Tip injection, and also.
Can you show the guide? You guide epicardial collateral. So once the wire crossed the CTO and entered the distal vessel, it was confirmed by means of epicardial collateral injection, contralateral injection. Please show previous one. Previous one, previous. Yes, this is the crucial as this step you show. Contralateral injections, epicardial collateral, and previous injection, our previous. Previous. This you show.
Yes,
The
yes.
collateral injection.
Yes, yes. So firstly, I want to do the precise chip, precise 3D wiring control, but the CTO region is very short. So that's why after checking the shaft of the wire into the two lumen, the guide wire tip is already reached the distal end. One back, please. One previous.
Previous one.
One
Yeah.
previous. One more previous. One more. One more. Yes.
And now you can.
So
you
that's
can
why
see. Yeah.
after checking, the guide wire tip is automatically getting into the distal part. But if it's difficult, maybe the angiographic 3D wiring is effective if the guide wire getting into the subintima.
Yeah.
But this kind of the tip injection is very important to see clearly.
But
And
there
my
is a
program
risk
today is
to get
if the guide
into
wire
the
getting
plaque.
subintima,
there's a risk to get into the plaque and then out
Yes, yes, yes,
again
yes.
at that point.
It's a plug and yeah, that point. So that's why I gently advance the guide wire because the guide wire is a conquest. So that's
Yeah.
why the possibilities are getting into the plug again. So that's why I gently advance it.
Yes, yes. By step, right.
And if I failed, maybe I will, if I failed, I would
Cross
go
course
to
ADR.
the Stingray ADR.
ADR.
So that's why,
That's the plan B.
yeah, this is the plan of the today.
Yeah. And another important thing actually, the proximal cap is so tough, you can show angiographically. The Corsair is unable to advance into the CTO segment. So we change the strategy of removal of the Corsair, and then with 1 mm balloon, hydrophilic balloon, we ultimately passed across the proximal cap and CTO segment and dilated. Now we want to, the next plan is exchange the Corsair, this Conquest Pro with a routine workhorse wire. That we are doing now, the present step. Next step.
So which balloon did
this is
pass
the-
then?
Yeah, that's
Okay.
Ryure?
Re-
Sorry, it is, I brought it from Japan. This is a
1 mm.
1.5 Japanese smallest
The
Hydrophilic
Rio Ray
thermo
10?
balloon.
thermo balloon.
Yeah, 10,
10,
exactly.
10.
Okay, a new balloon
Which
by
ultimately cross the
Terumo.
proximal cap, tough calcific proximal cap.
A new balloon
Yeah,
by
yeah, it's
Terumo,
very-
5 millimeter length only,
Distal.
low profile.
Yeah, low profile. Yeah, but this is also available from until the 3.0, and but maybe another 1.0 balloon might be passed through.
No, still. Some-
So
Small.
next step is to exchange over the Corsair to
Yes.
workhorse wire.
Exactly. Workhorse wire, exactly.
Yes,
What best?
it's very dangerous. But I have to advance the conquest wire into the distal part. Oh, yeah, still after opening the Corsair cannot pass.
Resistance is there.
This is a 1.0 balloon, so that's why.
So you
But I have a Canabel also.
still have trouble getting the Corsair through?
Yeah.
Yes.
So maybe a
Proximal
bigger
cap
balloon.
Resistance is offered.
Yes, I
Yes.
understand. Yeah, bigger balloon is safer.
Yeah,
So,
that's the problem with the small balloons, that you create only small lumen. But it's
Yes.
unusual that the Corsair doesn't follow.
After dilatation, it has to cross actually once you.
No, it's a 1-0,
Yeah.
a 1-0 balloon.
But still 1-0 is
1.0.
that
1.0.
size.
Yeah. Low profile below.
This are part.
File of course
Free.
is less than 1-0.
見えない。どこや？
No, you have to.
どこや？
No, 1 minute.
The file of
Where
course
is
is
the
less than
proximal
1-0. It has to cross once you have dilated at the lesion site actually.
来てる？
わかんないです。
あ、来た。
Going?
So now trapping technique is
No, with
applied
2 mm
again.
balloon dilating the cap.
Okay.
I need a 2.0 balloon.
Yeah.
Give me a 2.0 balloon deflation.
One.
Sorry.
Yeah, deflate.
Yeah, so
What
the
size is it
1.0
now?
balloon is very nice, but this problem. 2.0.
2 mm balloon now. Next.
Next.
Graded dilatation with 2 mm balloon.
Yeah, there was a calcium ring on the ibis, and
The sticking might be at the calcium
I-
actually specular than that.
Really very tough. Actually, it is pushing the guide out. Actually, when we are pushing the Corsair and this one.
okay,
The problem is,
we'll
while
watch
casting
you
up
on the
above
side
everything.
screen. Yeah, always note that you are still live,
Okay.
but we switch the main screen now to SGPGI again.
Is almost exchanged to a routine Cyan wire, workhorse wire,
ションワイヤー。
and then subsequently we are doing pre-dilatation. And we have checked with IVAS also regarding the composition of the plaque and all these, and
20.
proximal parking point of the stent also just is assessing. Dr. Okamura?
Yeah, yes.
And distally the vessel is diseased in the IVAS.
Okay.
Distally diseased vessel.
Okay, so will you maybe 6 or 7 back, please?
Down.
So did you do an IVUS run
I'll
already
explain.
for the
Yes,
distal
right.
vessel?
Back. Back.
Yes, yes.
already. So will you show the IVUS?
We should
Dr.
see,
Okamura
yeah,
explains that regarding
because
IVUS findings, please.
it's very important
Yeah,
to
yeah.
plan not to have too extensive stents in the LED. Where is the landing zone?
Yes, exactly.
So please tell us, let us, or please explain the IVUS that you found.
Yes.
Yes. And you and yes. So this is the IVUS. Yeah, this is the distal part. This is the distal LED.
Yeah,
And
let's
I
have it
provide
on the main
IVUS.
screen.
Can you see the IVUS?
We
Yes.
see. They should enlarge it.
IVUS,
Please go
IVUS,
to the
please.
main screen.
IVUS, please.
Boa,
IVUS, please.
IVUS.
Show us on the main screen.
And you is IVUS is here.
Main screen, IVUS, please.
Yeah, we can
Okay.
see.
Main
yeah,
screen.
it's
This
okay.
is the distal. This is the mid part. Yeah, this is some classification. So
Yeah.
this is the mid part of the LED. So can you see the angio? Angio is this point.
Angiographic and
We
IVUS
should have the
combination.
split screen. Yeah,
Yes,
I
yes.
think that is
Okay,
good.
Yes.
Yes.
So this is the tip of the IVUS is at the location of the plug, the starting of the plug. More distal, there is no plug. It is a shrink. But the IVUS pointed area, there is a plug classification. So that's why the stented area is just beyond this IVUS marking point. So maybe 38 or so because of the marker.
So, and the
So,
left
also
main
the
is
important
free,
point is the
so
proximal part.
separate origin, left LEDs. LED, ramus, circumflex, separate origins.
So,
There are no two left main.
yes,
Okay.
this one. This one is, can you see the IVUS?
yeah, we
So
see.
the Limus is coming from the 4 o'clock.
Both whites you show, please. IVUS, both whites is there, na? Ah, that's
Ah,
all.
Okay.
You show
3
that one.
o'clock. The Limus.
Freeze,
So the
freeze that one, freeze.
LED is maybe
Ah, exactly.
275 or 30. So please show me the angle, maybe from the AP coda.
Epicoda.
Apical
to
line.
see
Yeah,
the
yeah.
Apical.
bifurcation.
Separation.
Ah,
Yes,
yeah,
yes,
yeah,
yeah.
yeah,
Okay,
this
okay.
one.
This.
Injection. You
Yes,
you
yes,
can
yes,
see.
So the IVUS marking is here, just at the ostium of the LED. So maybe we should put the stent at the ostium of the LED because of from the IVUS information. Beyond this area, LMT is much bigger, maybe 60 or so. So that's why the catheter is not sitting well. So I want to put the
sitting.
stent just ostium of the LED.
Yeah.
So maybe 38 275, 38, 275. I want to put
But the IVUS sizing at the diseased vessel, please.
this part.
IVUS sizing at the diseased LED,
Yes,
mid
yes.
segment.
Yeah, distal part is 2.5 is might be
2.5,
better, but,
2.5.
I want to see the distal part.
Okay.
Yeah, yeah.
Yeah.
Just a moment.
More distal, more distal.
More.
To the normal side. More distal, more. Okay. More.
Here it 2.5.
Yes,
please.
yeah, 2.5
Yeah,
is much
but
better.
you- is better.
2.5
If you
is
want to
okay.
stay with one stent,
And
of
then-
course you need to find the stent that also goes up to 4.0 proximal.
So maybe
4.
I don't clearly know the exact length of the stenting area because of the eagle eye, but maybe 38 might be okay. If it is needed, I want to put the stent as a distal part after the proximal stenting. But the marking maybe 2.5, 38 is okay. こう同じ角度かな違うね。これ何してるの？
Zeiss.
Yeah.
先の角度にしますか。
これ進めたらな。
はい。
OK。
Caudal,
Ah,
caudal,
caudal view.
caudal.
OK, caudal view.
Uh,
And I want to
Okay.
see the previous image.
previous image.
Yes, yes. Previous image, Akshay.
Okay.
Can you show?
Previous image.
Previous image. No, that caudal view image.
Okay, okay.
This is the one.
Please
Did you,
go to
did you tell what stand?
Ikkada, landmark.
yes, reference.
38.
2.5
James.
38 giants.
Zain, Zain,
Zain.
Same.
Same angle?
Same angle.
Same.
2141
angulation.
Okay.
OK, OK, OK.
Okay. Okay. Thank you.
Can I give injection?
Anyway, you are always true lumen, so
Yeah,
there is
arito
no
between
problem in injecting antigrade contrast here.
But
Okay, okay.
I usually say gentle injection.
Gentle, gentle
Gentle,
injection.
gentle. Very important.
Very particular, actually.
Yeah, maybe 1 millimeter distal because giants is on the marker.
Yeah,
Yes.
yeah, fine, fine. That's sufficient. I think it's
Okay.
That
sufficient.
looks good.
A gentle injection.
Yeah, yeah, yeah.
Yeah, here, here.
Exact.
Okay, okay. Please inflation.
Sufficient.
10 atmosphere.
10.
Go 10.
10.
12.
12.
Deflation.
So if you agree, we will switch because they are just in the process of reverse card and would come back when you have optimized.
Yeah,
and,
please go.
Did
Oh,
the
okay.
IVUS, okay?
Okay, thank you. Yes, yes. Okay, thank you. Okay,
Dr.
so,
Kapardhi, we are back with you.
so just now I finished. Yeah, can you
Yes,
hear
yes.
me? Can you
That
hear me?
Okamura is already the case was
Already I
finished.
finished. So this is the final shot of the after stenting. So the 2.538 giants was implanted, ostium to the mid part of the LAD, and the 3.0 balloon, 3.5 post balloon dilatation. One back please. So distal part is I already checked, but the IVUS it's shrinked. So maybe it will be growing up. And also the proximal part, a relatively proximal part beyond the ostium of the LAD. So that's why I insufflated the 3.5 balloon again. But maybe LMT is just the separated LAD and separated LAD and LCX coronary. So will you show the IVUS image of the last one?
How proximally optimized, yeah? With
The distal
3.5
part.
balloon. Can you show that?
Yeah, this is a 3.5. The distal part is okay, but the proximal part is relatively just beyond the exit. But this is just the almost the no LMT, short LMT. So that's why maybe I want to leave it.
Yeah.
So I finally checked the angle and it was okay.
Yeah, that's an excellent
Hope
result.
The distal vessel
and,
will grow, okay?
Perfect demonstration of IVUS-guided puncture. Thank you very much.
Thank you so much. Thank you so much.
Thank you.
Thank you. So thank you.
Well done, Kapardhi.
Sorry.